progressing. Okay, I'm good.
Great. Good deal. Well, thanks everyone for joining us for day 2, our second session in celebration of National Public Health Week. I'm Don Simpson, and I'm very, very privileged to serve as a program director for the MPH program at the Arkansas Colleges of Health Education. We have Dr. Simon with us today, and I will do our land acknowledgement, make an introduction, and then if you have questions throughout the presentation, please type them into the chat area, and we'll ask these to Dr. Simon following his presentation. Excuse me. So as we get going, I think it's important to recognize that we are on the unceded homelands of Native people who have ongoing cultural and spiritual connections to the places we live. We acknowledge and send gratitude to the land and to the people who have stewarded it through the generations. In acknowledging this history, we do not intend a superficial action that somehow releases us from the obligations of righting past wrongs. We acknowledge that we live in a world where privileged peoples have gained wealth by colonizing, enslaving, and oppressing other peoples and communities. We see the ongoing effects of these practices and policies every day, and we work to be accountable to our part in this history. We each come from a different history. We have each lived a unique life. We bring those experiences to the work we do today. We affirm and celebrate our commitment to the difficult and joyous work we must do excuse me, to transform our communities into ones built on justice and on caring for each other and our lands. It's a pleasure to introduce Dr. Bala Simon. He's a board-certified family and preventive medicine physician. Dr. Simon obtained his MD from India and completed a family medicine residency from UAMS, College of Medicine, Department of Family and Preventive Medicine in Little Rock, Arkansas. He further completed a fellowship at the Centers for Disease Control and Prevention, Preventive Medicine Residency and Fellowship Program, and became board certified in public health and general preventive medicine. He obtained his Master of Public Health with emphasis in epidemiology from Tulane University's Celia Scott Weatherhead School of Public Health and Tropical Medicine. He further obtained his doctorate in public health with emphasis in health policy and epidemiology from the UAMS Fay W. Bozeman College of Public Health. He is also board certified in obesity medicine and lifestyle medicine. Dr. Simon wears many hats, and he serves as the Deputy Medical Officer, Chief Medical Officer for the Arkansas Department of Health and the State Chronic Disease Director. In this capacity, he provides clinical oversight and leadership to several clinical programs, including chronic disease programs such as heart disease, stroke, diabetes, cancer, tobacco control and prevention, nutrition and physical activity, and substance misuse and injury prevention across the state through Arkansas Department of Health's 94 local health units. Additionally, he serves as adjunct clinical associate professor at UAMS Family Medicine Center Clinic, where he provides clinical care to patients and teaches medical students and residents. He also serves as an adjunct associate professor at the Department of Epidemiology in the UMS College of Public Health, where he teaches managerial and clinical epidemiology to public health students. He most recently acquired the role as the inaugural Dr. Joseph H. Bates Preventive Medicine Residency Program Director at UAMS. He is widely published in national and international peer-reviewed journals and serves on a number of boards and organizations, and has received multiple awards for his contributions to improving the health of Arkansans and beyond. It's a privilege to have him with us today, and I'm going to turn it over to him as he talks about Public Health 3.0 in a changing healthcare landscape. Thank you, Dr. Bala.
Well, thank you, Dr. Simpson, for your generous introduction, and I'm so glad to be here. And I'm wearing my hat as the president-elect of the Arkansas Public Health Association in my conversation or presentation this afternoon. I've been in public health and clinical medicine for over 25 years and have practiced, as Dr. Simpson said, originally from India, practiced in India, spent some time in the United Kingdom, in Scotland, been in the Caribbean island of Trinidad and Tobago, and been in the United States practicing both the clinical medicine and public health for the past 24 years now. So I feel like I have something to talk about with my span of experience on this topic, which is very near and dear to me. Now, when I submitted this topic, as you could see in the announcement, it came out as Public Health 3.0 in a changing health care landscape. Subsequently, like I think 10 days before, I said, well, I should really say it as changing healthcare and health landscape because these are two different things. And that's something I'm going to highlight the differences and overlap between what we consider as healthcare and what we consider as health. And there's a lack of understanding among the public about it. And some of the problems I'm going to talk about stems from this lack of understanding. Now, as it's pretty evident to say that we are in a new generation, new era, a new year, new political landscape. Yesterday I had a thought. Maybe I should have said public instead of Public Health 3.0, maybe Public Health in Crossroads. But I said, well, let me just retain the original title and express my thoughts and views. So all my the slides have references and backing from that, and I may combine that with some of my personal opinions and perspectives as well. And I'm presenting wearing the hat under the auspices of Arkansas Public Health Association. So let me start with just an overview of what is Public Health 3.0 and what I mean by changing healthcare or health landscape. And I added the last bullet 765 for a particular reason because it is easy to remember the three numbers. It's in descending order in a same way, 765, because I'm going to make my presentation revolve around 765. 7 reasons why the healthcare is how it is. 6 reasons why the health of our communities and our nation are how they are, and 5 things what Public Health 3.0 teaches us in moving forward. Let me start with the big picture. Life expectancy in the United States and other high-income countries are peers. I'm going to present some data on about some doom and gloom, and I promise I will end with some optimism towards the end on what optimism Public Health 3.0 offers in our journey. But let me start with saying that in the last decade, we have lost almost 5 years of life expectancy in the United States compared to our peers. What this slide shows is the life expectancy for our peers, high income countries, in 2021 was 82.5, whereas for America, it is 77.2. We have lost almost 5 years in the last decade or decade and a half. This is pretty significant. Why America is entering into an era where we are living fewer lives, fewer years than in the centuries past. To make it worse, we spend the most in the healthcare arena or the health expenditure than any other industrial countries, particularly those developed countries who were listed there. So you can, in this chart, you could see USA on your far right on your screen with the blue dot, where our life expectancy is 77.2, whereas our healthcare expenditure per capita is close to 12K, right? So why is our life expectancy low and why we are spending more on the healthcare expenditure. So those are the two key questions we're going to answer along the presentation and see what Public Health 3.0 can offer. So why Americans pay more for healthcare than any other nation? And why is the life expectancy in America lower than any other developed nation? So let's jump in. As I mentioned, I'm going to summarize the entire presentation with that 765 rule. Here's the first one. 7 reasons why Americans pay more for healthcare than any other nation. This is a piece published in USA Today, which pretty succinctly talks in a abbreviated way on the reasons. Number 1, lack of price limits. We have more hospitals filled with specialists than any other industrialized nations. Medicine has gotten so compartmentalized and so categorical that you can find a specialist for a great toe compared to the other toes. I'm just saying it in a joking way, but we spend close to 4.5 trillion in this country, and about 30% of that goes to the hospitals. 20% goes to the doctors. 7% goes to 9% goes to the prescription drugs. So we have an enormous amount of money without price limits being spread across. And this is a problem, because when I talk about the hospitals being the major drivers, I'm not talking about the hospitals in the rural communities. I'm talking about the bigger hospitals or the health systems which claim their nonprofit status, but really how much in return they are providing the uncompensated care, which is by law the EMTALA rules. So a 2012 study showed that the nonprofit hospitals were spared $37.4 billion in federal and state and local tax waivers. But at the same year, they paid only compensated only 15.2 billion in uncompensated care. So twice the amount of the money has been raked by these big hospital systems. Then the doctors and the hospitals get paid for services, not for outcomes. Again, we are in an era, we talk about value-based care, but we still have a foot in the fee for service. So this is another big problem. We talk about the outcomes, but we are not ready to take our foot off of fee for service. So as a result, the fee for service continues and we are raking more cost for our healthcare. Specialists. In America, we have 2 specialists for every primary care physician, whereas in the other Western nations, Canada and Western Europe, you have 2 primary care physicians for every specialist. And of course, the orthopedic surgeons get paid almost 2 or 3 times more than the primary care physicians. So that is a disincentivizing primary care, making more going into the specialty care and hence increasing the cost. Administrative costs. This is another big thing. Medicare has the lowest administrative cost, whereas the private insurance has as high as 24%, which is a lot of these administrative costs revolve around prior authorization, approvals, and a lot of these paperwork and administrative costs. Well, the Affordable Care Act or the Obamacare capped the administrative cost to 15%, but that helps some, but it still is a lot of administrative cost that's inflating the health spending. Healthcare pricing. Again, this is a mystery. You could be treated at one healthcare system for a heart cath for $5,000, another for $50,000. Why is there huge disparity? There are some fixes to this recently with the Healthcare Transparency Act, but there's no penalty implemented for hospitals not disclosing their healthcare spending. Only 21% of the hospitals have abided by this healthcare pricing or Healthcare Transparency Act. So 21% is still leaves a lot of them who do not disclose the pricing of that. And Americans pay far more for prescription drugs. A cost of Wegovy or Zepbound can be $1,000 per month in the United States, whereas it costs merely $155 in Canada or $59 in Germany. So why is there cost? Well, part of the problem is when the Medicare Part D came about, there was this donut hole which was filled by having the senior citizens get the medications refilled. However, the trade-off was there was no price negotiations with the pharmaceutical companies. So I know different administrations tried to work on this, but we have a long way to go. Lastly, the private equity. The Wall Street investors, they are heavily invested in the hospitals, and they are heavily invested in big group practices, and hence they have these price gouging essentially, and essentially they have more in revenue generated in health. So these the private equity firms are betting on these monies, and of course their lobbyists don't want to touch any of these scrutiny the government regulators have on these hospitals and health systems, which are heavily backed by the Wall Street investors. So this article talks succinctly about these 7 reasons why we have high healthcare costs compared to any other Western nation. Now let's go back to the second question. Why is our life expectancy dropping? Why we are 5 years, our life expectancy is 5 years lower than the Western nations? Well, these are the top 10 causes. COVID used to be number 3 during the 2021, 20 and 21. However, it's not anymore the case. 8 out of the 10 causes of leading causes of death are chronic diseases, heart disease, cancer. The 2 which are not chronic diseases are unintentional injuries, and of course influenza and pneumonia, which is number 9. So when you look at the actual causes, this is a study published by the Institute of Health Metrics and Evaluation. They looked at the actual causes of death and the attributable causes of death in America, which has a huge impact on the life expectancy. On your left, you see the top 10 causes. We looked at the heart disease, cancer, and all. To your right, you see the attributable causes. In other words, these are the underlying causes for the heart disease, cancer, and all of them, starting with poor diet. We are a fast food nation, and fast foods get subsidies, and they are cheaper than the produce you get in the supermarkets. Smoking is still a big problem. High blood pressure, BMI, which translates to obesity, physical inactivity, high blood sugar. So you name it. So a lot of these are behavioral habits, are behavioral characteristics, which contributes to it. Now, this begs the question, what are really population determinants of health? I'm sure some of you have seen the Institute of Clinical System Improvements chart on what goes into your health. Only 20% of the health is determined by healthcare. Rest of the 80% or things happen outside the physician's office, outside the healthcare system, outside the hospital. They are the health behaviors. We just saw them, right? The tobacco, diet, exercise, alcohol, sexual activity. They are the physical environment where you live. And they are the socioeconomic factors, the social determinants of health. Education. We know that studies have shown that individuals who have a lower education have a higher risk of heart disease, a higher risk of dying from heart disease. Job status, which is a surrogate of income. Family and social support. Income, again, it's related to the job status, but income with the costs of the produce, the fresh fruits and vegetables increasing, income plays a role in individuals' choices. And then the community safety. So 80% of health happens outside a healthcare setting. So this is important to know because not just our healthcare landscape is changing, but our health is also changing. Now, even more stark picture. 10 years ago, there was a cry for help about midlife mortality. One can always dismiss these chronic diseases or of older people, right? Of all, well, no, not really. I'm a family and preventive medicine doc. I see, when I started my practice 25 years ago, most of the patients with diabetes, heart disease are in their 60s. Not anymore. I see patients with diabetes, heart disease, heart failure, kidney disease in their 40s, and some of them in the late 30s. So a lot has to do with the 80% of what goes into the health. Now, that's one shift we see. The other shift is 10 years ago, there was a cry on the midlife mortality happening. These are Americans 45 to 54 years of age who are dying, the increase in mortality. What this chart shows is the US has the higher midlife mortality compared to our peers. France, Germany, where the midlife mortality is going down, ours is going up. So this is an aberrant phenomenon which everyone wanted to see what is causing, because these are the productive young adults, right? So one, we know that in this chart on your left, you can see the medical costs which are going up. I mentioned about increasing diabetes, high blood pressure, kidney disease, heart failure among those in the younger, the 40 years, right? But on the right side of this chart, you see the newer causes, drug overdose, that has skyrocketed, right? The alcohol induced causes, suicide. This is a big problem. Homicides, mental health, these are all increasing in the midlife population. So this is going to be, this was a concern that not just these chronic diseases are of older age, but we are seeing a midlife mortality increase in this country as well. So what are the three key causes, some of the causes, key causes for deaths of despair? So deaths of despair by definition are deaths by suicide, drug overdose, or alcohol related diseases are termed as deaths of despair by some of the experts in that field. And when they examined in the last 10, 20 years, that's skyrocketing. Over 150,000 Americans lost their lives in just 1 year in 2022 from suicide, alcohol, and drugs. And these are all middle-aged Americans who lost their lives. In Arkansas, deaths of despair. Again, in the same year, we had over 1,200 Arkansans lost their lives. 500, over 500 for suicide. another 100 and something for alcohol, and close to 600 for drug overdose deaths. Now, so what is happening in our society? So we are having increasing mortality, not just from chronic diseases like high diabetes, high blood pressure, heart failure, and stroke and cancer, but we are also having a double whammy effect in the midlife mortality due to suicide, alcohol, drug overdose. So there was a study conducted, a systematic review to find what are the deaths of despair, who it impacts disproportionately. What they found was it's impacting disproportionately the blue collar whites. Most of them live in rural areas, African American population, Hispanic population, low socioeconomic position, and educational. Again, some of them are related to the social determinants, unemployed, working in jobs with high insecurity, living in rural areas. See, these are, again, there's a lot of connections to the social determinants outside health impacting their longevity. So we are having a double whammy effect on our life expectancy. One, increase in chronic diseases, explosion of chronic diseases in the older and increasing in the midlife, and compounded with the deaths of despair, which is making the midlife mortality high as well. So, how did we get here? There was a really nice article by Wolf, an opinion piece or editorial in the American Journal of Public Health, talking about the malignant neglect, accounting for public's disinterest in deteriorating health outcomes in the United States. So remember at the beginning, I talked to you about the 765. I'm going to talk about the 6 reasons why, according to Wolf, that why we are here with this malignant neglect. Number one, I think public here, this editorial talks about public being unaware that a crisis exists. I use this example about the frog in a hot water or a toad. If you put a frog or a toad in a hot water on a lukewarm water and slowly raise the temperature, it will stay there, get bloated, and die. Whereas if you put a toad or frog in a hot water, it'll jump out. So there is a complacency about this crisis that is happening due to chronic diseases, due to these deaths of despair. Oftentimes, deaths of despair has been neglected or thought of as others' problem. So public is unaware that a crisis that, losing 5 years of life expectancy is huge. It impacts the GDP of the nation, the productivity, and it has long-term implications. Skepticism about science. I don't need to tell much about this to this audience. Everyone is a scientist now with all these social media, Facebook, you name it. Their opinions are science, or sort of. And also, there is also complacency about crisis of other people. This is public health. We are all in this together. It's not the marginalized communities who are being dealing with all these emerging chronic diseases. It is the blue collar whites. It is the rural population. It is the African American populations, the Hispanic population. So it's not, we can't negate this as crisis of other, but we are. So that's the second reason the article talks about skepticism about science and crisis of other. And then we talked elaborately about the US health disadvantage is systemic and affecting all groups. So the health disadvantage, mainly he talks about, is the access to healthcare, the affordability of healthcare. That is, we are more and more becoming a society of haves and have-nots. And the number one reason for bankruptcy in our country is medical bills. Medical debt is the number one reason. and lack of investment in upstream factors. When I say upstream factors, I'm talking about the root causes, the social determinants of health. I say this another story to the medical students that two brothers walked along a stream, and one brother sees a kid, being swept by the stream, and he jumps in and tried to pull that kid out and gets on the shore. And then they walk a little more. He sees another kid coming down the stream. So the brother jumps and saves them. And then they walk a little further. He sees another kid coming down the stream, and he turns around. He sees the brother running away. And he, appalled, he said, "Where are you running away? I'm trying to save this kid. Stay with me." But the other brother says, "No, I'm going to go upstream to see who is throwing these babies in the water in the first place, so I can stop at the upstream these problems." So health, as I mentioned, only 20% happens in the healthcare. Other 80% happens in the communities, in the places we live, places we work. That's where we need to invest in. So this article talks about the lack of investment in upstream factors. When you see some of the best health countries with the best health outcomes, like Nordic countries, they invest twice the amount in upstream factors, the social factors, the education, the housing, the transportation, which plays a huge role in how people view their health. And then there is paralysis by analysis, overwhelmed by the scale of crisis. Well, this is too big of a problem. We can't solve this. And so many people start tinkering around the corner and giving up when they don't see the results. And then lastly, healthcare, a top concern for legislators, politicians, and everyone, but not health. So this is where the dichotomy is. Health is not healthcare. Well, you can get better your health when you go to the healthcare, but health is not healthcare. And we need to have that concept instilled in our public, in our own self, and people choose lifestyle over longevity and the quality of life. That is the biggest challenge for this malignant neglect. So these are the 6 reasons Wolf talks about why there is a public disinterest in the health outcomes, which is deteriorating in the United States. Now, let's come to Public Health 3.0. So Public Health 3.0, public health has been the fundamental things which has been helping the communities. The biggest success in health we had were from clean water and sanitation from the late 1800s, early 1900s. That is the public health 1.0, when we were able to identify and provide clean water, sanitation, and consequently, we saw biggest drop in the leading causes of death of the 19th century, diarrheal diseases, infectious diseases. And then we go to the public health 2.0, which is somewhat in the middle of the 19th century, where the advent of antibiotics, advent of vaccinations came about. So the public health 1.0, where there's a tremendous growth in knowledge and tools, both in medicine and public health happen, there was an uneven access to care and care and also to public health. Whereas when the public health 2.0 came, that's when the governmental public health came about. That's when the focus became investing in public health programs, HIV program, TB programs across, and other cancer screening programs came. Now, moving fast forward in the last decade or so, the concept of Public Health 3.0 came about in the middle of, I believe it was in 2016, I think 2016, when Public Health 3.4 came about with the focus on upstream factors, focus on engaging not just the core public health or healthcare, but reaching beyond, engaging multiple sectors, engaging community partners to generate collective impact, going upstream, finding the person who's throwing the baby in the stream, finding, addressing the root causes, improving the social determinants, and hence downstream having a better impact in public health. So the CDC talks about the three buckets of prevention. There is healthcare and then the public health, and there is some overlap in where the traditional clinical prevention happens at healthcare, where increasingly use of evidence-based services happen, and then innovations where provide outside health settings happen, and then there is population health or public health, where there are community wide activities happen in implementing the entire population, not just the people who are in healthcare sector, but the population as a whole. So there is an overlap between public health and healthcare where we need to work across sectors. Lastly, this is my last slide. What Public Health 3.0 recommended back in 2016, and it resonates today, is focusing on what we do as a society to ensure the conditions in which everyone can be healthy, where we eat, play, work. So this is one of the primary principles of Public Health 3.0, is to creating a society to ensure that everyone can be healthy, and addressing upstream factors, social determinants of health is very critical. For people in this call, in this teams, health may be in their top 5 priority or top 2 priority, but people in the community who are non-healthcare, a lot of my patients who I provide clinical care, the Medicaid patients, health is not even in the top 10. Their top 10 may be paying for their rent, paying for their utilities. Of course, with the inflation, cost is increasing, child care, transportation, so many other things. So if we want to really make health as a priority for all population, we need to address some of the disparities upstream which are due to social determinants of health. Lastly, I mentioned to you, I will close with the 7, 6, 5. Here are the 5 critical dimensions or recommendations. For Public Health 3.0, we need strong public health or healthcare leadership and workforce. We have a huge population of need. We need strategic partnerships beyond the confines of a healthcare entity, beyond the confines of traditional public health. We need to reach out to public-private partners. We need flexible and sustained funding, not one-time pilot funding. We need sustained funding if we need to build a strong infrastructure. And we need timely and locally relevant data, metrics, and analytics. And lastly, we need to have a sound public health infrastructure that would serve the entire population, not those who go to the health care hospital or a physician's office to seek health. So we need to move from a sick care system to a well care system or a health system where it embraces not just healthcare, but also the communities and public health in general. So with that, I will close it's 12:40. We have 10 minutes at least for Q&A. I'm glad to answer any of Q&A. Thank you.
Thank you, Dr. Simon. And I really appreciate the the succinct overview. Great job. A quick question, at least to start with, and thank you so much for referencing Karen DeSalvo's work regarding the recommendations and highlighting some of those things that were put forward. Question is, 3.0 was launched in 2016, wherein public health leaders serve as chief health strategists. So the roles have sort of evolved. This transition is supposed to be from episodic, non-integrated care toward value-based care. The question is, how will we be able to measure improvements in social determinants of health without timely, actionable data, or for that matter, funded research and programming?
That's a great question. That's a loaded question, per se. So let me start piecing it out. So the episodic non-integrated care were towards value-based care. This is a heartburn to me and many health leaders. We've been tinkering this for almost 15, 20 years now, and CMMS put together this 50 value-based care models and all. But as long as you keep another foot in fee for service, this is not going to change. We need bold leadership. We need, the chief health strategist, the article they talk about at the community level, but it applies at the national level too. Unless you say that, well, I'm going to stop the fee for service. Let's do bundle payment or let's do value-based payment. Then you're talking. If I am a primary care physician seeing 30 patients in my office, I'm going to get paid for the level 3, level 4 diabetes care, heart disease care, regardless. Well, I may participate in a value-based care program, but it's educational purpose. Unless it hits my bottom line, I'm not going to be shaken. So we need that tandem shift in that. And then second part of the question, how will we be able to measure improvements in social determinants of health? Like health is more than health, public health, or healthcare. It is what happens in our day-to-day life. That's social determinants of health. Again, these are not my words. These are from the experts in the community. The only way to measure improvement of social determinants of health happening is some of this things, broader societal things happening. What had shown being successful are the minimum wage increase, the livable housing, the livable neighborhoods. Some of the states are, particularly East Coast, West Coast states are doing it and seeing the difference in the downstream effect, improving social determinants. That's why I'm saying, like, for population who are struggling with the social determinants of health, health is not going to be in the top 10 priority at all. So we need to be a more equitable society in addressing these upstream factors so that health becomes a priority. So I agree with the comment, we need funded research and programming to address that part of it.
Thank you. Other questions? I think Jennifer's typing one, maybe. I think we have time for one more.
And just while waiting for that question, I'll put a plug in. We have Arkansas Public Health Association has partnered with the Society of Public Health Educators and having our annual conference this Friday at UAMS Spine Center, 12th floor. We still take walk-in registrations if anyone is interested. I think, Dr. Simpson is part of the planning committee. He can send the link for that if he hasn't already. So we encourage you to support the Arkansas Public Health Association. We need everyone's voice and everyone at the table to solve these complex problems.
Okay. Question answered. Well, that will wrap us up for today. Thank you so much, Dr. Simon, for your enthusiasm and continued commitment to the populations we serve. And thank you, everyone, for joining. We'll see you tomorrow if possible. Same time, same place. Thanks a lot, and have a good rest of the day.
Bye.